morning. Welcome, everyone. I'm Lindsay Haas. I'm the Executive Director for the California Telehealth Resource Center, and I'd like to welcome you all to our 10th Annual Telehealth Summit. We're here to talk about the Golden State for Telehealth, what's next for California. And if we can go to the next slide, I'm going to start with a quick housekeeping update. This is a disclaimer that this session is purely for informational purposes. CTRC has no relevant financial interest, arrangement, or affiliation with any of the organizations related to commercial products or services discussed during the Telehealth Summit. And now that we have the housekeeping completed, I'd like to introduce to you Ms. Kim Kleppinger. She is our president of the California Telehealth Network and OCHIN's Chief Experience Officer. She has over 35 years of professional experience leading organizations with growth life skill cycles, including from startup through expansion and acquisition stages. She's currently focusing on expanding CTN and OCHIN's products and services to underserved communities in support of equitable stance to patient care and access. She's also responsible for ensuring strong account management services, maximizing of HRSA grant-funded services, including our CTRC, and the internal executive sponsor of People and Culture. We're really glad to have Kim joining us today. She has an extensive background beyond telehealth and medical health information. She also is an early supporter of CTN, which she'll talk about a little bit here in the startup days, years before our affiliation with Region. And she's bringing the story of the need for broadband and telehealth to the FCC directly. Starting in the Oregon Health Network in 2008, about the same time CTN was founded, which later merged with OHN and OCHIN in 2013. It's one of the most successful FCC programs nationally. A lot of background from Kim, educational certifications, most recently leadership from Harvard Business School, and has founded and supported a nonprofit for 17 years for caregivers of children with special needs, including training and supporting caregivers on special education, state and federal laws. Kim, you have quite a resume, so I think I'll stop there and turn it over to you and let you kick us off. And thank you for joining us.
Yeah, thanks, Lindsay. Welcome, everybody. After that, I feel both old and tired. But again, everything that together we do, this is very much a we effort that we continue every single day to pick up in order to get that very needed access to care to our patients. And I don't see all of you and I don't know all of you, but I want to thank all of you, because I know each one of you in your own way have been both picking up that backpack and carrying it every single day to continue our march to make sure that every patient has access to care, regardless of location, regardless of ability to pay. And it's only through your efforts that we have been seeing so much success, as well as the efforts of the staff. The CTRC staff are small but mighty, work tirelessly in order to be your partner, so that together we do not leave any patient unserved in the state of California. So thank you all, and really thank you for your fortitude over these last couple of years, which we know has really led to the success of people being able to get through the pandemic in the way that they've been able to get through it. So thank you everybody. But a little bit on CTN, just a little bit of background. Lindsay's right. I think it was 2005 or something like that. I flew down and walked the campus of UC Davis with lots of folks seeing how telehealth was really working and what the plans were for expansion of telehealth in the state. And then from there, have been partnering either formally or informally since that time, and have been really proud to do so. So with California Telehealth Network, what the mission is to continue to promote and expand broadband, for which, as we all know, is the foundation bedrock. In order to have that virtual care, telehealth needs to have to ride on, making sure to increase access in California throughout the state with broadband, and make sure that adoption of broadband is both affordable, but also supported by good project management, good, working between our members and the broadband providers, which is not a light endeavor, as you guys know, so that we can ease the burden of adoption to our members. Today, we have 109 CTN members, 17 hospitals, 91 clinics, and are bringing 6.4 and have brought 6.4 million in subsidies to California since 2018. So we're pretty proud of that. Next slide, please. Just a summary of how we touch the state in various capacities. Again, the names, there's OCHN, which, CTN is a subsidiary of OCHN, and then CTRC is housed within CTN, but really it's all together that we work in the state in order to continue to make sure that there's tools for patients, whether it's EHR, whether it's virtual care, whether it's broadband, whether it's technical assistance, that at the end of the day, together we're collaborating in order to work with you and your patients in the state of California. This last year, we've helped support over 5 million annual visits for patients, again, many of them virtual care visits, 500,000 are Medi-Cal patients. California is we have most footprint in California than any other state in the US, and continue to just really enlarge our footprint there again in the efforts to expand care. We have our first critical access hospital going live as we foray into inpatient, Southern Humboldt, which is a CTN member, a CTRC member, and has been for a long time, as well as now a CTN or a OCHN EHR member. So they've been really great to work with. Next slide, please. So CTN and CTRC together, as a telehealth training center and infrastructure. As I said before, CTN began in 2007, but it was a couple of years before that for which the work actually really started in order to get CTN up and running, collaborating with the FCC, lots of plane trips out to Washington, D.C. to bring the story of California and the need for broadband infrastructure and virtual care to the ears of those sitting in those offices at the FCC, so that they really understand the diversity of the state. I have driven the state many, many times, from the top to the bottom and clear across, most recently even this September, and did the whole rural side of the state, and really again saw where broadband was at, where broadband was not at, and it just reinforced that our work needs to continue to extend broadband out to many of those areas that does not have broadband. CTN is considered a leading consortium, as is CTRC is a leading program at the HRSA level, which we're really proud of, again, small but mighty. and all together as part with OCHIN as an innovation center to make sure that we're bringing solutions to provide equitable care to our patients and equitable access for our patients. Next slide. The CTRC is on-demand resources. You can go to the website. You can see lots and lots of tools there, videos, webinars, white papers. It really is a one-stop shop. And then you can do what I do, which is send an email and kind of just talk to you personally. I love the human connection, so they're always ready and willing and available for a reach out if you would like to have just a one-on-one conversation or hear more about how we can continue to help you and your organization even better. And we lead with equity and we lead with technical expertise. So that is one of the values of being a partner with OCHIN, is that the CTRC staff can often turn to technical experts that sit within OCHIN to get questions answered and information. And again, CTRC has been funded since 2006. And this is the wonderful, very hardworking, very dedicated team. Aislinn, Jeannie, Shuba, Lindsay, and then myself. So thank you. I'm going to turn it over to Lindsay. And again, just really from the bottom of my heart, thank you all for everything that you have done for your organizations and your patients. We wouldn't be here without you.
Thank you, Kim. I very much remember you driving through California in the recent past and hearing about the dead spots you were hitting. And so we do still have a lot of work to do there. And one of the images that sticks with me coming over to CTRC under Kim's leadership is her explanation of the three-legged stool for telehealth. It's not just telehealth, it's the connectivity and it's the people and the telehealth. So that combination makes our three-legged stool. And so with that, I'm going to talk a little more about CTRC before we get to our keynote. Most of you are here. Hopefully you understand the value of virtual care and telehealth, but we really wanted to make sure from CTRC's perspective that we're being inclusive of everyone in the community who can benefit from telehealth. So looking at how telehealth can support not only patients, but their communities and their community-based organizations, our primary care providers, and the shortages that we're seeing in the state of California, the specialists, and thinking about how virtual care and telehealth are advancing more access to specialists that patients and Californians need, as well as the health plans as we look at the future of CalAIMS and other value-based models. In addition to creating that access point, health plans also have a role in virtual care. And if we could go to the next slide. This is something that CTRC, if you've noticed our publications on our website and resources coming out of the COVID-19 pandemic, we're really starting to see virtual care evolve to a new level of integration with care and services. And you can see that across the spectrum here of care delivery, we can insert virtual care, but really, if we hone in on the middle there, we're really talking about people. We've highlighted community health workers. As the technology advances, it's important that we don't forget that we need people out there helping our patients and communities connect and use the technology to its fullest potential. And so please keep watching our website for resources and tools as we continue to be on the edge in California of advancing this work. I think the insights that you all give us in our work groups and sessions, in addition to those of you who call in and ask us questions and join join our summit. It's really valuable to us to keep a pulse on what's happening around us in our communities in California. And if we could go to the next slide. Many folks were hoping that at the end of this pandemic, we would go back to the way things were in 2019. And while we're getting stability, which is much needed and to much relief here, telehealth is not going away. We're seeing evidence of it being integrated more regularly, coming out of a public health emergency into the regular day-to-day operations. So I really like to think of this as more of an evolution of virtual care and telehealth as we move forward. And so you're here at the right place to learn more about that and what that means to you and your practice and communities. And we can go to the next slide here. CTRC was founded under our funder, the Health Resources Services Administration, HRSA, under the Office of Rural Health Policy, and that's no longer where we're at today. We're with the Office of Advancing Telehealth, but really honing in on that rural connection there in telehealth and the ability to create access points in communities that do not have the appropriate providers or healthcare services. We really wanted to call out how telehealth is improving access in rural care. So 9% of our population in California is considered living in a rural area. And 9% might not sound like a huge percentage, but for Californians, that's over 3.5 million patients. So it is a big number of individuals that it is impacting. So across the country, about 17% of folks are in rural areas, but also report having a disability, which is compared to 11.7% of folks in urban areas. So we're seeing a contrast in disabilities, rural versus urban. And then we start thinking about agricultural communities, and 11% of our state's doctors practice in these communities and really are specialized on, the specialists are even harder to find. And we have an example here of the Activate program that's starting to provide solutions connecting those clinical settings to the home environments, making it easier for access. And then finally, mental health. A lot of open discussion as of late on mental health. The CDC reports that there's a higher suicide rate in less densely populated areas. So we're correlating that to rural populations and really thinking about how having access to mental health through telehealth and also the substance use disorder treatments in rural communities is really creating a better pathway to get folks the right care at the right time in the best way appropriate for them. Thank you. So we know we have barriers. It's not all there yet. So we've talked a little bit about the broadband access. So just know CTRC is well connected and we have resources for you there. And we can get not only you as an organization, but we can also get patients connected to the FCC programs to help offset their broadband costs and or cell phone. We know that clinical and operational support, there can never be enough out there, and we have resources for you there too. Not only do we have our resources on our website, but you can also call or submit an email form with specific questions and help finding what you need. And then finally, sustainability. Technology is not inexpensive, so we need to really make the best use of our funds, and we can really help you navigate what that means, help you in your selection of products, help you in your implementations, and really build a sustainable telehealth program or enhance a program that you may already have in place. Thank you. I'm super proud of Kim. You mentioned a small and mighty team. We saw the 5 headshots. It's really 3 folks. We have Shubha Devadas, Aislinn Taylor, and Jeannie Russell, who are really making the magic happen with a lot of support and friends throughout. But I really want to call out that during the COVID pandemic, not only did they show up, but they did so much for California. They experienced a 600% increase in technical assistance in the first few months of the pandemic. So they went from a phone call here and there to bringing off the hook and answered every call very amazingly and well. We served over 15,000 individuals since 2019, continued to build, update, and curate resources, including webinars, workshops, and so forth. Since December of 2019, so right before it was officially a public health emergency, to today, we have over 1,500 hours of training and technical assistance in the state of California. And that demand is not declining. It is flatlining, but it's not going down. So we're still busy and welcome all of your calls and questions, and really makes our day to connect with you as our community members. And go to the next slide. So what we offer as a program, if you're not familiar with us, we are, as I've mentioned, funded by the Health Resources and Services Administration. And we're really here to support providers, payers, patients, communities, family members on using virtual care tools and really implementing programs around telehealth. So the teams listed out here some great things. We do fast turnaround. You can get one-on-one training and technical assistance. Our library is very full of amazing resources. We do workshops, webinars. You all have toolkits, guides. We offer reimbursement guidance, although slight disclaimer there, it is moving fast here in California. So we do our best and we'll come back to you if we don't have an answer. And then, like I mentioned, the patient assistance with resources, and that would also include their families and caregivers. And then all of this really being federally funded makes us unbiased. We are not vendor specific. We do try to come in with a very neutral lens and look at each person's needs when they call and offer guidance. But again, no vendor affiliation and fully federally funded by HRSA for this program here. And we can go to the next slide. So you will have access to this in Whova. So thank you for those who are joining in Whova today, which is our mobile application and desktop application for the event. And our information is here. You can go to our website. You can call our 800 number. You could even probably put a chat in right now and somebody will get back to you. So we look forward to serving you and would love your help in spreading the word about who we are and how we can help you. And Kim, we went a little fast, so I don't know if you wanted to add anything before I go through the last couple slides here, but we have a great agenda. We're really excited. And Kim, do you have anything?
I think just the thing is to confirm is that in addition to all of this, we also have a strong government relations presence and footprint in California. California is one of the only states for which we have, I think we have about 5 people working within and outside of Sacramento in order to continue to support policies, especially the priority policies have been continued funding and payment for virtual care visits, again, regardless of location or type. As you know, when payment dries up, so does everything else. So we spend a lot of resources and are happy to do that. So in the state at the political level, in order to carry the message on telehealth and the need for telehealth and continued payment and support. So I think that that's important to understand. And then we tie that work back to at the federal level. So we tie that work back to DC. Also, to continue to carry that message. So it's a very comprehensive approach that we take: people, technology, information, political advocacy, and it really takes it just takes that full approach in order to continue to keep virtual care alive and well and expanding.
Thank you, Kim. I really appreciate that, and a great reminder of the ecosystem that we're all working in and living in, and the connections there. So I really appreciate that. And thank you for joining us today, Kim, too. If we could go to the next slide. I want to transition us a little bit to what's coming up in our agenda today. As policy continues to be a hot topic, we have a great agenda, and Kim, that was really timely, your comment there on what's going on. And so some other topics that have also received a lot of attention in the last year: lessons learned from the pandemic, digital equity, as well as rural health utilization and specialty programs. So you'll get a lot of viewpoints and a lot of different presentations over the next couple days. So hopefully you're in a comfortable chair or maybe a beautiful spot outside joining us. And if we can go to the next slide, I would really like to spend a moment here really thanking our sponsors. We had our event partner, Ocean, who helped us really coordinate, put the technology together, and keep us all on track and on time. So thank you to Ocean for that. Our silver sponsor, Spectrum Enterprise, who has supported this summit many times in the past and continues to do so. Thank you. And then to our scholarship sponsors, we had 3 this year, including the California Healthcare Foundation, Foley and Lardner LLP, and Anthem Blue Cross, all of which their contributions went to offsetting the cost for attendees to join our event, making it possible for us to keep our fees. And I think we have somebody off mute here.
It was making it.
So thank you. And I was waiting for my dog to bark, so I think we're okay. Something has to give when we're all working from home. So with that, let's go to our next slide. And we will begin our first session of the 2022 Telehealth Summit. And we're glad you could join us today for today's keynote session on telehealth and the triage of value-based health and digital equity. I am once again Lindsay Haas, your Executive Director for the CTRC, and I will be your moderator this session. Today's session, we can go to the next slide, is purely for informational purposes. The California Telehealth Resource Center has no relevant financial interest, arrangement, or affiliation with any organizations related to commercial products or services discussed during the Telehealth Summit. Before we get started, I wanted to review a few tips for the Whova event platform we're using today. Whova makes it easy to access event features using web portal or their mobile app. Explore the agenda to view upcoming sessions, use the community tab to view topics, and start to engage in conversations with other attendees. Also, make sure your profile is up to date so that other attendees know who you are, and we'll use this to get to know you and network with you. Today's session is being recorded and will be available to view through the event platform by next week. And lastly, feel free to post your questions in the Whova chat window. We'll hold the last few minutes of this session for a good Q&A. And with that, I'd like to introduce our guest speaker, Dr. Nicole Turner-Lee from the Center for Technology Innovation, Brookings Institute. Dr. Lee is a senior fellow in governance studies with the director of the Center for Technology Innovation, serves as a co-editor-in-chief of Tech Tank. Dr. Lee researches public policy designed to enable equitable access to technology across the US and to really harness its power to create change in communities across the world. And she has a forthcoming book on the US digital divide titled Digitally Invisible: How the Internet is Creating the New Underclass. It is with a warm heart, and I'm just really thrilled you were able to join us today, Dr. Nicole Turner-Lee. I'd like to introduce you and actually give you the floor. It's all yours.
Well, thank you so much there, Lindsay, and thank you to Kim and to all of you that got up this morning to participate in this great conference. I don't know about you, but I learned a lot just listening to all the resources that are available. I'm honored. Listen, it's not often that I get invited to speak to friends like yourselves. I think Kim put it well. You are the heroes and sheroes of this pandemic. Without the medical professionals, leaders, experts, administrators that are actually participating on this event today, we wouldn't have made it. And we still have a road to climb. This challenge is not over. And so it's important for us to keep placing that at the center of the conversations that we're having when it comes to the continuation of telehealth. Let me just start before I throw up my slides. It's interesting. I'm going to show some slides, but I have to tell you I'm from New York and I do like to use a lot of hand movement and I'm pretty spontaneous. When I'm done, you're going to feel like you just listened to a church service because I'm an evangelical when it comes to issues related to healthcare and getting healthcare to people wherever they are located. So my goal today is to really break down what I think is what I consider a triage. We cannot, as it's been mentioned, have telehealth, health equity, care equity, unless we also have digital equity. So I'm going to spend some time there. But before I do that, let me just share, and I'm going to have the person just prompt my cover slide first before I actually delve into my full slide presentation. But let me share with you why I'm excited and sad at the same time. We all know that in the last 2 years, the COVID pandemic just ravaged through our communities. Some of us even have friends and family who were affected. I know on my side, I lost 6 people to this ravenous disease. And now here in the state of California, where we're seeing a public health crisis of monkeypox, we're going to continue to see what people are actually talking about, the long-term implications of long COVID. We have a lot to do, my friends, when it comes to disrupting how we deliver healthcare here in the United States. And more importantly, when we think about what the pandemic did to affect those folks that were already disproportionately affected by their lack of healthcare. Can I come down your lane and scoot up next to you in a chair virtually? I'm sitting right beside you right there on your sofa or at your desk. We know that communities of color, particularly those that are historically disadvantaged, low income, non-English speaking, elderly, were primarily impacted by this pandemic. And more importantly, they were impacted before the pandemic. Let me come down and really unpack what that means. My colleague, Dr. Rashawn Ray and Dr. Keon Gilbert from Johns Hopkins University and University of Maryland, respectively, made an argument that the reason why we saw the increase in disproportionate impact of COVID-19 on communities of color had a lot to do with what we already know, which were comorbidities, but they also related to the density of housing, the lack of proximity to healthcare, the insufficient access that existed when it came to secondary and tertiary care for physicians, the lack of trust in these systems, not being able to see the doctor on a regular basis or engage around preventative or diagnostic care and clinical care. Friends, we knew before the pandemic that these challenges were in our presence. And here we are today on what I would consider a national pilot of telehealth, an accelerated national pilot that has proven not only will people go online for remote care, but even our most medically underserved will actually utilize this resource for remote care if given the opportunity. I think I want to agree with Kim that this is not going away. My first exposure to telehealth happened almost 30 years ago. I know I don't look that young, but it happened 30 years ago. I was in the state of Alaska looking at our secondary and tertiary care intervention of dermatological services. I actually, after that, got to see what was called by the ISPs back then, the doctor in the box, when we were using things like Skype and other remote services that are much more archaic than what we have today, what we're doing today. Got to see stroke care done by the University of South Carolina, where they actually administered a stroke intervention from the main town to a rural town just by the nature of telehealth. Friends, all of us that are on this call, we're no strangers to this. In fact, we've been part of the fan club for a long while. And we've also been part of this fan club that addresses the types of health inequities and care inequities that we constantly see. Let me go back to what I said earlier. You are the heroes and the sheroes on this call. You are the ones when we saw hospitals in medical distress, when we saw people who were afraid to go to the doctor to be tested for COVID, when we saw folks that were trying to figure out how to deal with other chronic conditions. You are the heroes and sheroes of this pandemic. And so what we got to talk about today, and go to my next slide, is why telehealth matters. And it's important for us, and I'll do this in the context of this discussion, really talk about these three equities: care, health, and digital. And most importantly, what I'd love to share with you today is why we must close the digital divide, particularly why we have to address broadband access if we're going to improve better patient outcomes, create more reciprocity in communications, and in the end, embolden efficiency and hope for communities that have been left behind. So bear with me if you won't mind. For the next 35 to 40 minutes, I promise not to take too long. I actually want to delve into this, and then we're going to have a little bit of time at the end for questions. So if you have questions, make sure you put them in the chat. But we're going to have a conversation, because I didn't come here just to be a preacher. I came here for some call and response so that we can leave this conversation, particularly for the state of California, much more entrenched and ready to have all hands on deck for what needs to happen for telehealth deployment universally, as well as adoption and use, and education for that matter, which I'll talk about in just a moment. Next slide. Why the need for equity when we talk about digital equity? I think it's been shared, the importance of telehealth when it comes to the type of medical equity. And let me just be clear, we're not yet there when it comes to the conformities and the consistencies when licensing and reimbursement, as well as certification. As I've mentioned, I've been doing this for almost 30 years, and we've been battling the same issues. And we all know federally, there's been a lot of incentive to move towards telehealth. In the pandemic, the CMS actually assisted, and Medicare and Medicaid assisted with waivers that basically prompted our ability to actually engage more expeditiously in telehealth. For some of us, that swipe of the pen took almost decades worth of work and made it an action in less than 24 to 48 to 1 week in terms of its implementation and use. And here we are today. We're actually seeing, just last week in Capitol Hill, we're seeing provisions that came with those waivers and exceptions being extended beyond the quote unquote pandemic response period. Friends, even our state regulators have become much more amenable to telehealth when it comes to thinking about modalities, whether it's synchronous or asynchronous, whether we're thinking about parity in payment, the extent to which we're seeing the type of funds evolving to local communities and community health clinics. We have seen some movement on our state regulators to actually understand the disruption of the technology. And more importantly, before I get to this slide, we're also seeing, I think, an appetite among the clinicians who actually see that remote healthcare can actually help offset the type of volume, not only that they were experiencing during the pandemic, but the continuity in client engagement that some doctors were not able to actually create as a result of, swamped schedules or the proximity of patients to care. I recently spoke before a group, and I remember one doctor said, and we all know reimbursement is still not settled. There are still challenges when it comes to parity of services of in-person versus online. But I remember talking to a young man who said, Dr. Lee, I can't get away from this remote health, because what I figured out during the course of my execution is that people who took 6 to 7 months for me to see have actually been able to come and get on their phone or at least listen to me, and I'm able to check their status. Friends, that is important, because the livelihood and the extent to which we have longevity in our wellness in this country is deteriorating. Again, let me go back and just remind people that you all know that some of these challenges existed way before the pandemic. These were not new challenges that we experienced. In fact, we saw many of these experiences when it came to health inequities happen, and we were some of the champions trying to make it work. When we think about, again, what we've been able to do with telehealth, yes, we need to figure out ways as practitioners, as state leaders, that we continue this, no longer as a movement, but as one of the components and complements of healthcare in this country. Listen, when I was working years ago in the city of Chicago, and I had my child around the same time that one of my colleagues did. She was the administrative assistant, and I was just the researcher at the time. I was volunteering, I believe, just getting paid as a volunteer to do some work in terms of programming. We both worked in one of the most dangerous and unkept and essentially one of those areas where the health depravities were so high that she and I had children around the same time, my son and she had a son. Both of our children had asthma. Her child had asthma similar to mine. I had the university health insurance as a graduate student. She relied upon the emergency room as her primary care physician. If you're following me on this, and it chokes me up every time I think about it, when my child got sick, I was able to take him to a primary or a secondary care therapist or a physician. When her child got sick, she was directed from the emergency room to go 2 or 3 bus routes to get to the secondary care specialist to check on her child. When my child got sick, I told my boss I was taking off my time because I was still a student and had another job. When her child got sick, she had to take off of work, which did not happen often. So as a result, there were stretches of weeks where her child did not have care. When my child got sick, I was able to not only follow up my doctor immediately and check in on the university health system. When her child got sick, she often would call in at the last minute or have to get her mother or a family friend to just make sure that child was comforted at the times of distress. My child grew out of asthma. Her child didn't, and has a series of chronic conditions, not only the chronic condition of poverty and systemic inequality, but the chronic condition of a medical respiratory condition that will stay with him for the rest of his life. Friends, health disparities are real in this country. And we have a responsibility to figure out ways to bring healthcare closer to the people. And I share that because one of the things that did work during the pandemic was the internet. I know that there are many of you that are listening to me that are not only doing this, but you ordered packages online, groceries online, communicated with friends and family. The internet worked. And the internet works so well that there are some of us that want to stay hybrid for the majority of our lives because we like the quality of life. But the internet didn't work for frontline workers. It didn't work well for people who had to show up in person. Didn't work well for some of those nurses and frontline responders. Didn't work well for ambulance drivers and others. Friends, we have to think about ways to actually not only encourage digital equity when it comes to deployment and adoption and use, but we also have to position the digital space that works in this healthcare space so that we create a new infrastructure that makes sense for the implementation of these services. I'm so glad that I'm talking to people from California because you tend to be above the curve. We kind of consider you in DC your own country when it comes to the types of policies and regulations and foresight that you have. But I share that because we're not going to make this work for people like Kathy, my former colleague, and others, if we don't solve the triage of services, care equity, health equity, and digital equity. So allow me just to share on this slide for just a moment, just why we need digital equity in this country. Then I'm going to wrap up and follow up with some recommendations before we go into Q&A. First and foremost, the lack of broadband access poses barriers for people seeking healthcare. 28% of rural residents lack home broadband access compared to 21% of suburban residents. May not seem like a huge difference, but that 28% of residents tend to also be less healthy than everybody else that lives in the suburbs, less proximity to healthcare. So we need to look at that type of broadband adoption to really make sense for why we need to solve the digital divide. Race also matters here. 80% of white adults own a desktop or computer. compared to 69% of Black adults and 67% of Hispanic adults. 38% of those who are Black and rural lack internet access. Come here with me. Come on here with me. When we look at the intersectionality of race, my friends, and if I threw in age, we see that the lack of adoption not only comes smaller and more narrow, but what it also does is it shows us that people have limited access to devices when they are trying to connect to high-speed broadband to engage in remote care. Third, people of color lean more towards smartphone ownership. More than 95% of African Americans and Latinos are smartphone dependent to get online. And what that means is they're not actually using what I'm using right now, a PC, to actually engage. They have to rely upon the power in their purse, in their pockets, oftentimes limited by data, oftentimes being a feature phone or sharing a phone with someone else. Friends, we're doing a study right now at Brookings. We've interviewed 2,500 people from the Black Belt of the United States of America. And we found that the majority of those people that live Black and Hispanic in the rural South just use a smartphone to get online for things like homework, shopping, healthcare, employment. Come on, what can we do just via a small device? I don't know about you, but my progressives get stronger just by the reliance that I have on screens in my everyday work. And then the other thing I want to add is providers are impacted by the lack of digital access, causing delays in care and preventative wellness. Not talking about your Comcast and your Verizon, my friends. Talk about all of you who have limited access to not only the resources to provision care, but also limited access where you actually work to be able to have a seamless connection to engage in remote care. Lindsay talked about she was afraid her dog was going to interrupt. We just had somebody who didn't have their phone on mute. Could you imagine what it's like to get a cancer diagnosis and that you drop your bandwidth in the middle of the discussion with your doctor or your doctor? And this is a true story because I watched this in the production of my book, which I'll talk about in a moment. Doctors sitting behind a library or a town hall just because it has stronger broadband to be able to communicate with the patient after hours. Friends, we have a challenge to have ahead of us when it comes to addressing digital equity. And I know you got covered for this conference, the health equity and the care equity components. I'm here to walk you down my lane of digital equity, which guarantees first-class digital citizenship for the people who are medically underserved. As it was mentioned, I'm writing a book, and this book is about the US digital divide, and it's not about the people who are connected. It's about what I call the digitally invisible, the people that we forgot. And in all honesty, we didn't really forget them. They're the ones in California and the city of Los Angeles that live on Skid Row. They're the people that we see in rural areas going towards places like Bakersfield. They are the folks that we know exist, but we think that they're digital natives because everything has migrated online versus being in line. These are the same people, my friends, that could not schedule a vaccination appointment because they didn't have online access. They were the same people, unfortunately, that could not talk to an elderly parent in a nursing home because they didn't have sufficient access. Friends, we have a lot to do in this country to close the digital divide. And that's why I can't stress enough, as it's been mentioned by Lindsay and Kim, the importance of having the infrastructure in place to make this a triage. It's like when I go to the emergency room of the doctor, they always do a couple of things. Some of them I don't like because I'm working on, exercising and being much more fit. They take my blood pressure, they take my weight and my height to determine if I've changed or things have altered. We don't talk about care equity, health equity, digital equity, when we're trying to implement what I think is the most advanced and innovative form of healthcare that we've ever imagined, the ability to engage with a doctor in a way that offers real-time communications. Next slide. And so when we think about closing the divide, I want to throw out for all of you before I get into recommendations that this is a care intervention. This is not about the typical things that we're used to dealing with as healthcare providers. This is not dealing with a particular chronic condition or disease or a less mild contagion. This is about allowing the infrastructure for healthcare to operate in sustainable and meaningful ways for everyone. Healthcare providers must be part of the solution by educating patients on telehealth, disseminating devices, and advocating for more broadband. I'm laying this out because I think it's really important for us to actually have this conversation. I love my job because I get to talk to various verticals. And when I talk to healthcare professionals, I want to blow your mind a little bit because I'm taking you into my space, which is a sociologist looking at the sociological implications of technology. Technology must be available, my friends, to improve patient outcomes and enrich the patient-provider experience, especially for medically underserved populations. Could you imagine what the experience would have been like of my colleague almost 30 years ago when she was taking 2 to 3 buses to get care for her asthmatic child? Technology matters. Oh, I'm getting warmed up here. So let me share another story because this is what I get excited about doing because I'm not just a person in Washington talking in regulatory speak. As part of my book, I traveled around the country and I visited places and asked people, local people like ourselves, what their internet access was like. It took me to Garrett County, Maryland to meet farmers. And it took me to Hartford, Connecticut to meet young people sitting on the stoops of McDonald's before there was a pandemic. It took me out to West Phoenix, Arizona, where the primary population of Latina children all carry cell phones in fear of deportation of their parents. So kids as young as 10 have a cell phone in their pocket in elementary school so they can be contacted if the parent is deported in Maricopa County. But when I was in West Phoenix, something happened that changed my whole trajectory of why I care about this stuff so much. I told you I'm a Black Baptist preacher, and if you ain't saying out, you better say amen, and I don't need to hear it because I want you to keep your mute button on. But I met in the parking lot of a library, a lady who was insistent with the librarian that she needed a library card. Her name was Frances, and I watched this lady argue with the librarians who basically said, lady, we cannot give you a card until you show us proof of your residence. And in her frustration, the lady walked out and she sat on the stoop in front of the library. And as a researcher, I followed her only to find out that she was upset and frustrated because she needed to use the computer at the library because she had just been diagnosed with cancer. Her doctor had just told her of the diagnosis through her smartphone, but her phone ran out of minutes and she was unable to pay. So she had to get to a library to be able to go into her email and figure out what was the next intervention strategy. I'll never forget that lady. In fact, sometimes I wonder where she is today, because that was 2 years ago before the pandemic. She didn't have a real resident. She said she had been just divorced. And she was trying to take care of her kid who was able to get into the library with a student ID to play some games while she was trying to take care of her personal business. Friends, technology can improve those outcomes. Frances explained to me that she didn't know about her diagnosis until the doctor told her the day after she left that office, and he was able to call her and talk to her about it, put on screen, showed her the slides of her x-rays. Friends, patient outcomes matter. And it's up to us to make sure that people like Frances, people like Kathy, people like the patients that you deal with every day have this one-on-one communication so that they have the opportunity of hope, what I started with. And modality matters. See, I'm getting choked up. Even real people like myself who work in policy get choked up. It matters because until we solve this digital divide, we're gonna have to have flexibility, my friends, between asynchronous, audio-only telehealth and perhaps real-time synchronous telehealth. We can't guarantee that everybody will be able to show up at a remote healthcare situation. I know, for example, we saw in terms of statistics that Blacks and Hispanics were more likely to use telehealth, but less likely to turn on their camera. Maybe embarrassed by the area in which they were living, maybe not able to know how the technology actually worked. I know my mother, who was in her late 70s, it took her a minute to realize she had to turn the camera around so she could actually see the doctor, not a wall. Friends, modality matters, and until we get to 100% universal deployment, we need to be sensitive to that. Now, I don't want to sound like a pessimist in my remaining time before I go into recommendations. There is hope out there. And I think California is going to be a huge beneficiary of what has just been passed, which is the Infrastructure Investment and Jobs Act. President Biden and Vice President Harris from the great state of California, they recognize that being connected to the internet matters. It matters for first-class citizenship. And they've allocated $65 billion to the bill that is being appropriated as we speak. And telehealth must be part of that equation. Right now, and I want to take this time so all of you know and you figure out how to mobilize around this, the money is going to go to the unserved communities first in terms of deployment. Those that are underserved, which may be urban areas that don't have as much competition. And then the third leg will be whatever's left over will go to anchor institutions, churches, clinics, etc. But again, that's predicated on what money is left. I'm sharing that with you all because states, localities, and tribal sovereign leaders are going to be responsible for making decisions on who gets this money. And so when I go into recommendations in a moment, I'm going to push the envelope even further. But you need to understand that a change is coming. This $55 billion has the ability for us to actually create the infrastructure necessary to mitigate the circumstances of the people that I've mentioned. But it's not going to happen, people, unless they know that you exist. And the unfortunate thing is that every state right now has an allocation of money, about 100 million to be exact, where they're engaged in capacity building. And you need to ask yourself as an association and coalition, as well as individual practitioners, are your voices being heard? Are you able to not only provide the type of clinical intervention and improve upon the quality of work, but can you also engage in closing the digital divide, making healthcare infrastructure an infrastructure asset? Let me say that again. Are you also able to engage to make healthcare infrastructure an additional infrastructure asset? Yeah, there are roads and bridges, there are dams that have to be built, but healthcare infrastructure is equally important, particularly when we look at the devastating numbers of people that we lost during the unforeseen pandemic and the public health crises that we're seeing with monkeypox. Friends, closing the digital divide is a health care matter. Closing the digital divide is a health care matter. And that is why I want to leave you with a couple of things to sort of whet your palate for what we need to do next. Next slide, which I think may not have my recommendations. So if you go back to the previous slide, I'm going to end up with my recommendations and then I'll take you there. First and foremost, and I am like a Baptist preacher, I'm just going to leave you with 3 recommendations and then we're going to go to Q&A. First and foremost, my friends, we need a triage approach to bringing and maintaining telehealth in our country. Care equity when it comes to value-based care, making care meaningful on the preventative and diagnostic side, ensuring that care is custom and tailored to the people that we're serving at all levels, regardless of income, regardless of demographic, regardless of location. Care equity is the first, health equity is the second, which you all notice, it's not the byline, right? It's not the thing we talk about at the end as the afterthought of the consequence. Health equity is part of the triage approach, and digital equity, which I spoke about just now. We need a triage approach if we're going to advance telehealth beyond the typical conversations that we've had, which place them in the helicopter. Let's bring it down to the people. We can use telehealth to complement, my friends. It doesn't have to replace healthcare, but I can tell you this 2-year pilot that we've had have shown the disruption is good for the industry, and it's time to change the way in which we administer healthcare. Now, we have a paper on this. You can go to the next slide now, that we just released. I'll be happy to put in the chat when there's Q&A. It's called The Roadmap to Telehealth, Efficacy, Care, Health, and Digital Equity. I'm not making this up. We released it last week. get it, read it, let's talk about it. But if we're going to do this right, I think what the association has done and what Lindsay has outlined with Kim, you have to have all three. They cannot operate in isolation of one another if you're going to have an efficient and resilient healthcare system. 2, we need to keep finding pathways that meet people where they are at. You know, I was a little girl. I used to love to read books. I was always that child with a book in front of my face. I didn't wear glasses back then. That's come with age. But I always had a book in front of me. And the reason I did was because of this love for learning, but also because there was a book bank that drove through my neighborhood back in the days that used to be like the ice cream truck. And they would park in the local park that was near the house. And we'd be able to go into the book bank and receive services. Friends, telehealth is that book bank. It is our ability to bring care where people are at. Let's think about it. It's frustrating. Some of us are not equally reimbursed on this. Some of us struggle with having the right equipment and training. Some of us are educating our patients on how to actually use telehealth and engage in a fruitful and productive discussion. Some of us have patients who get the text message that the telehealth session is starting, and they don't even log on. Those frustrations do not outnumber our ability to bring healthcare to where people are at. As I mentioned earlier, a lot of people died of COVID-19, not necessarily because the virus just stuck on them, but because they had a series of consequential factors, factors beyond their control, their housing, their physical and health status, things that they could not control that made them more susceptible. We need to bring healthcare through telehealth directly where people are at. We need to be that mobile book bank. We need to care for Francis, care for Kathy, care for the other people that we know. We need to make sure that they live fruitful and resilient lives because they got a lot to live for. We owe that to them in advancing this new medium. And third, we need to be at the table. I hope when we go in the Q&A that we talk about this. Where are the medical professionals when it comes to the negotiation and the settlement of broadband infrastructure in communities and cities across the state of California? Who's hearing what healthcare professionals have to say when it comes to access to broadband, access to devices, access to training? The way that the current bill is set up for the infrastructure grant, my friends, it not only has deployment in it, but it has digital equity training and literacy resources. It actually also has the affordable connectivity program that will allow us to actually connect residents to discounts on broadband service. $30, as a matter of fact, for people to be eligible to apply that to their monthly broadband through the affordable connectivity program, and $100 to get a device. We need to accelerate this. And our patients need to understand that this new ecosystem, this new healthcare ecosystem, entails our ability not just to provide for them when they are sick, but to make sure that we provide in moments when they are well. Friends, I cannot share with you enough how many times I want to just bring all of you to the table to speak to the decision makers in your states and at the federal government who need to hear your voice. See, we think that telehealth will be a byproduct, much like we think that we'll have better education in terms of distance learning, better opportunities for work, better opportunities for social and civic engagement. But being healthy in this country is not a byproduct. It's not an afterthought. You know, I was reading yesterday in the Wall Street Journal, I believe it was, about the impacts of long COVID on our labor force and the fact that we may have strong job numbers, but we're gonna have a lot of people unable to go back to work because of the after effects of having COVID and what that has done in terms of brain fog, nervous system, fatigue. We're gonna need this remote healthcare as a way to keep in touch with those folks who are experiencing symptoms or not, but don't have the bandwidth to actually come in and see us. And friends, this is not to say that we can't keep pressing on reimbursement parity, and we cannot keep pressing on eligible services. As it was mentioned, telehealth and telepsychiatry has been done extremely well at a time where this nation has been polarized and the individual and emotional mindsets of people have been deteriorating. But we can't fight battle for battle because policymakers don't understand who we are. We need them to pull up more seats at the table so that we can be part of the conversation on where broadband infrastructure lies. First, we need a triage approach to telehealth. Care equity, health equity, digital equity. We need to ensure that we can serve everyone, most definitely the medically underserved, in the places where they live, interact, and the places where expect us to show up. And we can do that through technology, provided we're somewhat modality neutral, and we continue to impress upon our states and federal government for the type of incentives that allow you as clinicians to continue to use this medium without fear that it will drive you out of business. And third, we need all of you, all 102 of you, to have a seat at the table in these new conversations around digital infrastructure. Healthcare is the new infrastructure. Healthcare is the new infrastructure. And it's not just the new infrastructure because we've got to figure out ways to make it more universal. I'll save that for my health advocacy friends. It's the new infrastructure because we've managed to do everything else online well, but not necessarily do the things that are of critical importance to citizens. First-class digital citizenship means that you not only get all these packages delivered to your doors, that's not a symbol of first-class digital citizenship, how many packages I could actually order and actually have delivered. First-class digital citizenship, it means that I am valued in an ever-evolving and increasingly informational world, a digital economy that does not foreclose on my visibility. You know, I call my book Digitally Invisible, based on the Ralph Ellison book, The Invisible Man. And as a woman of color, I know what it's like to be invisible, to be in a room and no one sees you sometimes, or to raise your hand and it's not called on. But I also know as a woman of color what it's like to exercise agency and to make sure people see me. I hope I haven't really terrified you. I'm from New York and I kind of talk loud. I'm talking into this computer. But I figured it out. But I call my book Digitally Invisible because there are millions of people who haven't. There's a farmer in Garrett County, Maryland, that can't figure out how to get broadband to his farm to actually order supplies and be productive against large farm industries. There's that woman, Frances, that just wants a library card so she can get on a public computer to talk to her doctor about her diagnosis. There are kids in Marion, Alabama, rural Marion, Alabama, who have tablets that were given to them as part of an iPad program, but without broadband, the principal said they are books without paper. We have to make closing the digital divide a health imperative. And I hope I've impressed upon all of you as you get ready to enjoy this conference and get into these substantive dialogues on what we're going to do to advance and to accelerate telehealth adoption and use. I hope I've given you something to think about. I hope I've given you names to actually ponder. I hope I've given you provocation to push the envelope, even when you have felt most frustrated. You're the heroes and sheroes. And the only way that we're going to make this work, my friends, is not by having a sociologist like myself sitting up here talking about the importance of closing the divide, but really making a circle of care, that understands that a triage approach, that care equity, health equity, digital equity, bringing technology to improve patient outcomes in real time, and making sure your voices are represented are going to matter. I hope we have some questions to entertain as part of this dialogue. I want to thank the California Telehealth Resource Center for having me. I want to thank all of you for actually paying attention and not putting me on snooze during this time. But you can find me at Dr. Turner Lee. Actually, I have a new Twitter because I had my old one taken, so I'm back to the new one, so I'll put it in the chat. And you can find that paper on the Brookings website at the Center for Technology Innovation or just at Brookings, where we actually go into detail. My colleague, Nia Yaraji, who's a health policy expert, Samantha Lai, who is actually a research analyst with us. It took us a year to write this paper, and partly because everything was changing. So I hope we'll have more conversation around this conversation that we're having today. Happy to answer any questions. I'll put my email in the chat. But thank you, all of you. Thank you for everything that you're doing today. And let's get in the weeds, okay? And let's get this done, because you've got a resource available to you in the state of California that makes this not impossible. So thank you very much. I appreciate you. And let's get to some questions, Lindsay. Hopefully we have some. If not, we can keep talking.
Absolutely. Thank you. So for folks, please put your questions in the Whova app. If you're on Zoom only, you can chat it in. We'll be watching those. And Dr. Nicole Turner Lee, thank you. Your energy and your passion is inspiring. And what a great way to kick off our event. So that first-class digital citizenship, the circle of care, our triage approach with the 3, care equity, health equity, and digital equity. I think it speaks a lot to what we all live and do every day, but hearing it from your perspective, it energizes me, and I hope it energizes our attendees to roll up our sleeves and get into this conference.
Yeah, I mean, because it's hard. Look, like I saw dermatological advancements, like I said, almost 30 years ago. And I would have never thought that we would be actually talking about remote healthcare today. I mean, honestly, I just had an allergic reaction to something I ate, and I'm allergic to shellfish and mercury. My doctor immediately did a telehealth visit and was able to diagnose whether or not I needed prednisone. And I think about like those conveniences that we have for those of us that have health insurance. I think about, all of the challenges we've had in serving the medically underserved. It's always about transportation. It's always about quality of care. It's about proximity to care. We have an opportunity to bring this closer. You know what I mean? And so we've got to capitalize on that. The government has incentivized us to do this. They have added, as you saw just recently, some additional incentives to keep going, but we've got to let them know this should be more permanent. That's sort of the reason why we wrote the paper.
Well, and Dr. Nicole, you started earlier talking about being a single mother with your colleague and your parallel roads. And for me, that really hit home as a single mother. And my daughter is now 16, but 16 years ago, as a single mother, it was a different environment with needing to get off work to go to the doctor's appointments, figure out childcare. If she was sick, I had to stay home with her, and we didn't have telecommuting as an option. And I wasn't with this great organization at that time. So that stress as a single parent really is relatable to me. And thinking about the conveniences we have today would have been a lot easier 16 years ago. So
yeah, you saw I got choked up because I think about that too, right? Because her son, it was like her son would be struggling and I couldn't do anything about it. I was a young mother like yourself. I was at that time, before I was divorced, a young married mother with an infant, and she couldn't take off work, and so you're so right. It's like that stress added to the ability to get quality care, which is what we have to keep paying attention to when we talk about things like telehealth, folks.
That's right. So I'm going to ask the fantastic event team if I'm maybe missing some questions. If there's questions on the Whova app that I'm not seeing, please point them out to me.
And I'm putting the link to the paper in the chat, which also if you could share on the Hoover app. I have Hoover. And for those of you that have reached out to me, I'm not good at Hoover. So if you want to contact me, email me or link. I'm on LinkedIn, but nturnerlee at brookings.edu. You can find me.
Thank you.
I try, Lindsay. I'm trying.
Oh, you're good. I have somebody coming on.
Yes, thank you guys so much. We do have one question through the Hoover platform, and that is, do you know of any programs or funding to connect rural patients to remote monitoring equipment, for example, blood pressure cuffs, smart watches, phones, thermometers, etc.?
Oh, I love that question. So I think it was already mentioned, but we should probably, Lindsay, I can get you more information. It's also in our paper. So the Federal Communications Commission has instituted the Connected Healthcare Pilot. And to date, they've given away millions of dollars. This is separate from the broadband money, which is the federally driven money being allocated to states, localities, and tribal lands. This is actually the FCC's rural broadband healthcare initiative that they've done for many years as part of universal service. So what I would suggest, and Lindsay, I can get this to you, that you look at, for the state of California in particular, what money is available through that program for tribal lands as well as non-tribal lands when it comes to devices. Now, there may be stipulations. I think that particular grant is primarily focused on deployment of healthcare institutions. So it invests a lot of money, much like the E-rate program invests in schools and hospitals and clinics, et cetera. But there are supports for equipment, for patient equipment, as well as medical provider equipment. And so the key thing there is to start there. I would say the second thing to do, and this is something I've been talking a lot to private healthcare companies, private health insurance companies. So in my work, and this is also part of my book, I'm trying to get the country, if we view healthcare as infrastructure, that we should be allowing for the purchase of devices for patients. So if you have a patient where a cardiometer that is remote will work to actually help you monitor high blood pressure, why can't we pay for it out of an insurance recovery? Across the country, there's actually a couple of places that are doing this. It's mostly been hospitals that are actually paying for iPads and other type of digital health tools. But one thing, and Lindsay, jump in if I'm wrong for the state of California, one thing we are challenged with is we are still defining, in addition to eligible services under telehealth and telemedicine, what are eligible reimbursable items for like digital health. It's still a murky line, which is really interesting. I sit on another committee where we're looking at AI in healthcare. And there's a lot of conversations on the use of digital health tools like Fitbits and others, and whether or not they're medically provisioned. We still have to engage in that conversation at the policy level, because again, what happens is companies on the fringe like Apple and others are developing these tools and they're not necessarily reimbursable by healthcare companies in all cases. Yeah. So let's keep talking about that, because I think as California becomes much more progressive through the center of providing resources, it's really important for people to know how much they can extend on the edge and how much they can actually, be right in the middle of the dialogue if they want to further advance their technical resources.
Yeah. So you're pretty spot on there as far as what's happening in California. I think a lot of what we're seeing right now is it considered a durable medical advice versus even a prescription, because it's hard anyway. So we do have very murky lines that are currently being defined. But the good news is the CTRC is available. And so what we'll recommend you do is connect with us specific to your use case and what your environment and situation is. And we will provide you as much information to help you determine the best way to do that. And if I can circle back, Dr. Lee, to the FCC programs you mentioned, those are, in addition to the connectivity, there's also the Lifeline program, which can also support reduced cost cell phone coverage for patients. And in California, both programs, we have been able to actually subsidize that more than the federal level. So there's a little bit more available to Californians. And so again, connect with CTRC. The information is on our website, but we have a lot of info there. So just reach out if you can't find it. And Dr. Lee will gladly take any information. We know you're on the pulse of what's happening across the country, and always love looking at what's out there and sharing it on our website. So.
Well, and real quickly, just because we don't want to encumber this, but that is why the Affordable Connectivity Program is a program that's inactive now. About 10 million plus people have benefited from this program. You as practitioners can actually serve as outreach centers for this program. They just actually codified a new agency to work on this. So the center can actually bring resources there. But you can promote to your clients that they can get $30 off in terms of broadband if they wanted to actually use some type of telecommunications interface for their medical care. And they can also have $100 towards a device. So we're seeing again there, and as Lindsay said, alongside of this has been the Universal Service Fund, which unfortunately has not been updated. So we'll see where that actually lands. But this money is going to be spent until it's all done.
Yep.
So just as my kids say, Mommy, didn't you say we had a budget of 100 for school shopping? We only spent $50, right? We got to spend it while we have it, is my point. And so knowing these programs and making sure that you get the pamphlets or you're able to put a flyer in your lobbies will be very helpful for people trying to challenge and toggle through these challenges.
Thank you. And I am seeing a bit of chat coming in now, so I'll take it from here and read them out loud. So we wanted to implement remote patient monitoring at our clinics, but they were predominantly FQHCs, and we found that the PPPM costs for RPM exceeded the $0 that we could get reimbursed for RPM at an FQHC. And then there's the follow-up. I had to go down a couple chats here to get that. Did something change? And Medi-Cal reimburses RPM at FQHCs now, and is okay. And this is specific to NVIDIA, compatible with Cerner. So this is getting really technical here. So not certain if there's a question in there for you or if you have a response to what I've read, but we can keep going through the chat if you'd like. But
so my mama always taught me, if you don't know, you don't answer. So what we can do is we'll park and lap that question. I mean, clearly there have been some provision changes when it comes to eligible reimbursements and coding, which I am very much familiar with. That's happening right now, and we're seeing more and more of that, but we can get back to you on that. And the key thing is there's still a conversation on threshold limits, and Lindsay, you know, maybe you want to chime in too, but thresholds on what can be paid, what's not reimbursable, what the reimbursable rate is. But I know that this is constantly changing, and I'm going to try and find, while I have you all on the chat, the recent bill that's actually addressing some of this, I think, that I just read that was just passed by the House in Washington.
sounds great. And I don't have any additional information, but again, if for specific, we'll take the technical questions back to our team to respond thoughtfully if we can't answer it in the general questions here. Let's see here. Thank you, Dr. Lee. The data you shared regarding accessing web tools and health access via smartphones versus PC was striking. Have you seen a difference between the quality of telehealth care via smartphone versus PC? What are your recommendations of alleviating this inequity?
You know, I love that question. So it's so interesting. In the recent study that we'll have out in the next, we're going to be doing a series of 4 papers at Brookings through the Center for Technology Innovation over the course of this year. So like I said, we're interviewing rural residents, and rural residents, for the most part, these are all 99% low-income census tract residents who live below, they're not in California, I think they go as far as Texas, but they live in typical areas, geographic areas considered poor. And I hope to replicate this study in tribal lands. And what we're finding is that they are very smartphone dependent when it comes to their use of technology. And that has a lot to do with the fact that their broadband access is primarily provisioned through some type of wireless connectivity, whether it's fixed wireless or wireless overall. Now, to your question, is that the most seamless form of connectivity? Not always, right? I mean, it's very difficult if you're in spotty coverage areas, or if you run out of, your data. I mean, there's other implications that we don't talk about often. I talk about in my book, which is the amount of data that people are using for these types of functions and the extent to which they still have to choose between, okay, do I call my doctor because my minutes are here, or do I watch that Netflix movie? Listen, it's not in our provision and it's not our authority to tell people what to do with their cell phones or mobile service. But we do have to get better. What you can do via tablet in terms of larger screen, what you can do in terms of a PC that's fixed in your house, it's much more private. It's much more seamless in terms of a hard connection to fiber. And those are the challenges that I think going forward, we're gonna have to insert into the debate. I mean, we just started with our first paper. Trust me, I'm not done yet, because I do think at some point we need to think about two things. One is we're gonna allow people to use their data for remote healthcare. And I do write about this in my book, Digitally Invisible, How the Internet is Creating the New Underclass, out January 2023. But I do write that we may need to do something called zero data, meaning, when we go in and we go to T-Mobile or Verizon or whatever company and we say, I want this phone, they say, oh, I'm gonna give you free Netflix and it's not gonna count against your minutes. Well, we don't do that when it comes to, I'm gonna give you free minutes to talk to your doctor. I'm gonna give you free minutes to go to school. I'm gonna give you free minutes to apply for public benefits like unemployment. And so we need to figure out how to offset that data while at the same time giving people the devices that are private. Francis was a great case. A woman using the library to look at her cancer diagnosis.
Yeah.
I mean, come on, how many of us do private transactions in public spaces? So we do need to move towards that. But for right now, one of the good things is we know that it's an on-ramp. And so some of the statistics, like I said, we saw during the COVID pandemic is we actually saw an increase of Black and Hispanic, low income, less educated elderly users of telehealth, primarily because they could use their cell phone. And in some instances, we had states that did either audio only, video, but they weren't necessarily preferencing one or the other for reimbursement, which made it easier for some of these families who were trying to manage, their broadband as well as these devices and literacy around these devices. I mean, look, I hate to say it, our next big issue, folks, is privacy, right? That's our next big issue. Next time I come back, Lindsay, we'll talk about privacy because all of our healthcare information in this remote portable world will be portable. I mean, look, our vaccination information is sitting at CVS, Walmart, or Walgreens. So going forward, we do need to talk about the next step of this, which is how do we ensure security and encryption of the data that comes across these visits. People don't understand if you don't do these visits within those platforms. I think someone just actually mentioned platform. I'm going to get, I think it was for Elsie, I'm going to get her some platforms that are synchronous and asynchronous. I know companies like there's companies that actually have those platforms where they're doing a really good job. Privy, others, I don't want to nudge them and who's sponsoring. But at the end of the day, we have adjusted technologically, but now we need to talk about privacy and security.
Yeah, agreed. And guess what? We have a resource for that too. So I just want to call out, I do see a lot of billing questions. We have other sessions. Dr. Nicole Turner-Lee is a subject matter expert, but not necessarily directly to billing. So we'll hold those questions, see if they get answered in the other sessions. And if we don't get to those, we'll do our best to respond back, but feel free to use CTRC's website to ask those questions. I'm just looking at the time. I'm going to wrap us up with a final question here. And we are going to look at everyone's questions and try to get back to everyone as quickly as possible. But this one is, I have a question about the geriatric population and the high need for one-on-one technical assistance, smartphones, passwords, etc. Not to mention ensuring they understand the legalities around HIPAA and technology. What successful strategies have you seen, or what would you recommend?
Okay, I just was typing for Newport. I'm sorry, question. So hold on. I will hurry. Okay. Newport just emailed me. I put my email in the chat in terms of health and vision literacy. So on the geriatric side, this is very interesting. I'll make it really brief. So we're not only seeing what I call advancements in technology on the static side, so the traditional complementary use of telehealth to traditional healthcare. We're also seeing AI in healthcare that is actually particularly helpful to the geriatric population when it comes to how they're actually supporting medication reminders, whether or not medication is properly being taken, the pill is the right size. We're going to see a lot more advancements in AI in healthcare. Even in the case of older people and mental health, voice assistant technologies are helping to sort of ease some of that strain and stress, and to create reminders for the type of healthcare provision. On the medical side of it, we're seeing AI in terms of geriatric discovery, helping us with, my mother has MDS, with trying to come to some types of new conclusions around medical conditions where we've had limited specialists in those areas. So I think going forward for me, and I write about this too, unfortunately I didn't talk too much about it, but I do write about this, and I'm partnered with AARP across the country on these issues. We have on the geriatric older American side, when it comes to technology, the reason why we have to make closing the divide an imperative is older Americans, when they reach past the age of 80, have more care needs, but less care help. More care needs, but less care help. And so as a result, we can actually use the technology that's been proven to help them live either at home or more sustainable livelihoods. And so we have to create the intervention where we close the divide, we create health equity, we create care equity to specifically service elderly populations. The same token, we need to be on the other side of history and ensure that they're benefiting from emerging technologies. How are they benefiting? I mean, I cannot say this enough. I'm so excited about technology. It's what I do every day. I get excited when I hear programs like Uber, who are actually providing free rides to the elderly to doctor's visits, right? Helps people like me who live in DC and my mother in New York to get her to a doctor. I get excited about AI and its use to help us help people age in place. So things like that, we should have more conversation about. Lindsay, I've just added 2 more pounds to your next conference, but let's keep talking about it. And I will add to the, and I see Newport, I'll send the foundations, but I'll send Lindsay a list of resources to add to the Telehealth Resource Center, which is what it's supposed to be. And hopefully reach out to the Resource Center. We'll get some resources up there, some old publications, some more granular publications, as well as some of these foundations and other places within the state of California that can be helpful. I don't want to overstay my welcome.
You're always welcome with us, and we really do appreciate your time today. But full acknowledgement, we are 2 minutes past, so I'm going to go ahead and wrap us up for this session, folks. We have a 15-minute break. We are starting at 10:45 a.m. Pacific time with our next session. So don't go too far. And Dr. Nicole Turner-Lee, thank you. Thank you. We appreciate you and your messaging. So thank you.
Thank you, everybody. Have a great conference. Thank you.
Thanks. Bye.
Bye.